Welcome to the second class in our four presentations we're doing updating you on PPACA for 2012. The material you're about to see, since I don't know when you're going to be looking at this webinar, the recording of it, the material was developed as of mid-September 2012. There have been lots of changes, particularly since then. The national election has been held, and quite candidly, a mind-boggling number of regulations have come out on a variety of subjects dealing with PPACA. So after the 1st of January 2013, there will probably be more seminars and physical presentations throughout the various markets. I would suggest that you stay in touch with your Ward & Brown sales representative to make sure that you get the information needed so that you can participate in the updated material. Much of what we're covering in our four presentations in this set of webinars will be adjusted and adapted as we move forward. This second program talks about the latest developments in the exchanges in California. Exchanges for each state was basically a way to implement the PPACA goal of universal coverage. The idea that every citizen was going to be covered by health insurance was conflicted with the fact that in many states there is not a robust enough market to actually insure people. In many states, insurance carriers were not comfortable expanding the types and qualities of the products, so the exchanges were an attempt to do that. Theoretically, if everyone in America was insured, if everyone in America was insured, the cost of insurance for everyone would be going down. That, of course, assumed that everyone is coming in paying their fair and appropriate share, which may not actually be the case. So the theory may not be true. But at a minimum, the concept that PPACA basically says to all citizens and all employer groups, play or pay. In other words, be involved in the healthcare system through health insurance or pay some type of tax penalty for an individual or penalty for an employer of a certain size meeting certain conditions. In California, we are moving forward regardless of what you may be hearing from other states. The individual exchange in California is scheduled to be up and operating January 1st, 2014. If any deadline is missed by a state, not likely missed here, but if a deadline is missed, then PPACA authorizes the federal government to come in and implement exchange in that particular state. There's been court challenges to the idea that a federal exchange is classified as a state exchange under PPACA, and that distinction does have some meaning. The question is, if a federal government comes into the state of Texas and runs a federal exchange in Texas, is that a quote-unquote state exchange, or is that a federal exchange being run in the state? And we're going to talk about why that has a difference in meaning in just a few minutes. It's all related to the impact of the ruling that the Supreme Court held dealing with Medicaid expansion. We covered that in our first program, but just as a quick backup, PPACA envisioned requiring all states to cover all people up to 133% of the federal poverty level on their Medicaid or Medi-Cal program. The states sued in the Supreme Court, and the Supreme Court ruled that the states did not have to do that. The states only had to continue covering people up to 100% of the federal poverty level. After that, in a state that does not expand, an individual would be eligible to go to the exchange if there was an exchange available. This chart shows where things stand as of early fall 2012 in terms of what states were doing what and moving forward. There's obviously been some movement since the recording of this webinar. In the red are those states that were opposed or leaning to oppose. In blue were those states that were leaning to participate. Of course, California is a deep, dark blue. We will move forward. Senator Orrin Hatch, with a study that was released through the Cato Institutes, was talking about that argument that I mentioned just a few moments ago, that if the federal government comes into any of those red states and starts an exchange, is that in fact a state exchange or a federal exchange run through the state? And the key difference is that PPACA requires an employer to pay a penalty if he's a certain size if his employees go through a state exchange and gets a premium credit to assist him to pay for it. The argument, while it seems rather nuanced, if a federal exchange being run in a state is not a state exchange, then the employers in those states would never get penalties because the employees going to that federal exchange in that state would not be getting premium credits from a state exchange. The IRS has ruled for the moment that any exchange being operated in a state, whether it's run by the federal government or the state government, is an exchange, and they will forward premium tax credits come 2014. As I said, though, without those credits, there would be no employer tax or penalty. We're going to discuss those employer tax or penalty in our next program dealing with the math of PPACA. California's exchange, HBEX is going to be operating by January 1st, 2014 if all plans continue, and they do appear to look that way. California wants to be self-sufficient by January 1st, 2015. The California Health Benefit Exchange, or HBEX, has hired a board of directors, a CEO, have contracted with a computer company to do the work, are entering into talks with insurance carriers, and they're basically doing everything to suggest that they will achieve this. Most of the information for this webinar concerning the California Exchange has been gotten through open material available on the internet. The California Open Meeting Laws means that the Exchange Board and everything it's doing, all its decisions and why and how it's making it, are all available for someone to read. So you can stay up to date by going through the California Exchange website and reading the same kind of things that go on in their board meetings as I've been doing. The board is governed by 5 members, and this is set up very similar to the Mr. Mib board. 2 governor appointees, as you see on the screen, 1 Senate appointee, 1 Assembly appointee, and the Secretary of Health and Human Services, which under Governor Brown is Diane Dooley. This board operates very similar to what the Major Risk, or Mr. Mib Medical Board does. In fact, much of California's success in developing exchange is because we've already had these kinds of experiences. We operate a Major Risk Board and have been doing it for years. We operated something called the Health Purchasing Co-Op, HBEX back then, and in all candor, if one were to read the governing laws for the HBEX from a decade ago, you would find just about everything that the California Exchange does at the same time. So it didn't take us very long to write that law, old law, or rewrite that old law into an exchange. In addition, we have a private functioning exchange here in the state, in the California Exchange with Ward and Brown. Of particular importance in showing the attitude that the Exchange Board is having, and as it affects the small group business here in California, is the fact that the Small Business Health Options Program, that's the small group exchange, hired Michael Lujan, former small group sales director for Blue Shield. Clearly they were looking for people with a market orientation. What's particularly relevant about the exchange, and you need to keep 2 things in mind. When we talk about the exchange in California, we're really talking about 2 separate entities operating differently under different rules for different purposes, but both reporting up to the main board. On the left hand, you have an individual exchange that will be insuring individuals, and on the right hand, you're going to have a small group exchange. The small group exchange is the equivalent to the old HBEX, the equivalent to California Choice. If an employer were to say, I'm going to drop coverage and send my people to the exchange, he wouldn't actually be making an accurate description, because an employer can't send his individual employees to the individual exchange. He can drop coverage and encourage them to go buy their own plan through the individual exchange, but once that employer releases his group, those individuals are free to do whatever they wish to do. But if an employer says, I'm going to buy my group insurance through the exchange, then what he means, or what he should mean, is that he's going to go through the shop. It'd be very much like buying his group insurance through California Choice. Essential benefits was defined by law and is being implemented by the exchange, and we talked about that in our prior program. The exchange will take testimony to determine which of our carriers and which of our plans in California will qualify, will in other words be constituted as a qualified plan, meeting essential benefits and meeting one of the metal designs you see outlined on your screen. A metal design is just a kind of a code word, if you will, for describing a policy that on average is going to cover 60% of the claims somebody might have, 70%, 80%, or 90%. And from the charts you can see bronze is 60%. So the minimum acceptable plan for the exchange for an individual will probably be a plan that meets at least the bronze level and has the essential benefits as outlined by our state law. The number of carriers who will be invited into the plan and into the exchange and the number of plans each one of those carriers have will be up to the exchange board. The way I like to think of it is, imagine if you've sold California Choice, imagine if our senior executives who manage and design California Choice decided to add 1,000 different plans into the California Choice plan design. You can see how complicated and difficult and frankly unwielding that would be. From a marketing point of view, it wouldn't make any sense. An exchange is going to have the same problem. They don't want just every carrier and every plan design. They want a set of plans and a set of carriers that will reflect the geographical area of doctors and hospitals that are covered, will reflect a variety of benefit levels, a variety of pricing points. They have to design their exchange the same way that California Choice does. That is, try to have a reason for being in the market which fits a variety of needs in a not too confusing kind of method. The exchange board will be making those decisions as 2013 unfolds. Obviously, the exchange board is going to have to consider network issues and the fact that if there's an area in our state that does not have doctors under contract or a PPO or an HMO, they're going to have to deal with plan designs that still provide medical care and cover health insurance for people who live in those non-network areas. There is, like I said, a difference between the individual and the small group. It is important to understand that the premium tax credits that are often talked about will only be available for individuals in the individual exchange. In the small group exchange, for the tiniest of companies, there will be some tax credits that will be available, but those are available to the marketplace even today, and they were last year as well. Broker involvement is not guaranteed in any given state's exchange, but it has been made clear by the exchange that brokers will be involved here in California. The out-of-pocket and the metal benefit levels, these bronze, silver, gold, and platinum, are yet to be decided because it's a very complicated decision. It's very difficult to imagine how do you compare 60% applicable coverage and benefits when you're comparing a staff model HMO with no deductible except per day deductibles in the hospital and a low copay and a 4-tier mandatory pharmacy benefit, and compare that to a $500, $2,500 out-of-pocket 3-tier pharmacy benefit, etc. Well, the exchange, under guidance with the federal government, is going to have to come up with some kind of calculator, if you will, to label the plans inside the exchange and outside the exchange as to whether they're going to be bronze, silver, gold, or platinum. We're going to come back to this discussion in our third webinar in this series. But for now, just recognize that what deductibles, what co-insurances, what stop loss, that's going to be defined by the exchange, and they'll have to have some range of them to make themselves price competitive. Don't bother trying to look at this chart too closely. It is really tiny writing. It basically reflects everything that has to be done for an exchange to be up and operating by 2014. California is advanced of everybody. We're about halfway through our 2012 March. There are about 6 states or so that I would put probably still in the blue line between 2010 and 2011. They've got a lot of wood still to chop. And then the other 40-some-odd states that are left, they're somewhere left of the chart as you're looking at it. And I'm teasing when I say left of the chart, obviously, but there's just a lot of states that have done absolutely nothing so far in the exchange. They're very little. The benchmarks here in California so far that have been met is July 2012. Accenture was contracted by the exchange on a $359 million contract to develop the technology that we're going to be talking about, because the exchange is heavily technology driven, particularly in the area of eligibility and enrollment. Accenture will be doing that. What was good news about that was, imagine if you had been hired to open a new insurance company. You certainly could have hired all the technology people and computer programmers and everything else and built the thing from scratch, or you could have simply outsourced the work, as the governing board for the exchange did with Accenture. Likewise, there's all sorts of tasks, including helping to sell and enroll through the exchange, that are being outsourced to people like our agents and brokers. By July 2013, which is less than a year from now, Accenture is supposed to have the launch of the web portal. We're going to talk about that web portal when it does, but if you're familiar with the Ward & Brown Quotomatic system or the Quotit services that Ward & Brown runs, imagine an individual and group portal that an individual could go to, or an employer could go to, or a broker could go to, and could look up and run a quote on everything that he wants to see. Well, that's what this exchange portal is all about that Accenture's developing, and they're reporting progress that they'll have the thing launched by July 2013. By October 2013, enrollments are going to have to be held. There's something of a misunderstanding amongst a lot of the brokers that because the law under PPACA will require all pre-existing conditions to be accepted without exception, the belief is that somebody's going to be able to wake up tomorrow, or maybe while they're in an auto accident driving to the hospital, they're going to be able to enroll online and get a plan the next day. Well, that just isn't how the private market works, and the fact is most of the exchanges are using private market carriers in California, except for Medi-Cal. Our exchanges will be using the same carriers and the same types of plans you currently sell. It'll be the same carriers and the same plans you'll be able to sell in the open market. And as most of you know, I can't call up Mr. HealthNet or Mr. Blue Shield today and get an effective date as an individual for tomorrow. Each carrier is going to have different rules, whether it be the first of the month after 60 days, 90 days, or whatever it may be. Clearly, in the case of group enrollments, you're going to have the same problem. So in order to have an exchange up and operating by January 1st, 2014, you obviously are going to have enrollments starting sometime in October or November of next year. So your customers and individuals are probably going to start seeing marketing of the exchange products. My guess would be sometime late summer 2013. By January 2014, the exchange will be operating live. People will be going to doctors, getting medical services, submitting claims, etc. Everything should be up and running. Accenture's biggest task that it has to complete before we can successfully run an exchange here in California is to create something called the Health and Education Electronic Records. This is the Accenture pictorial vision of everything that has to be completed by them for this exchange record system to work. This was taken off of public open records. As you can see, there's lots of plan management, financial management, eligibility, enrollment, etc. I've superimposed on top of the screen a secondary look specifically in terms of eligibility to try to demonstrate the complexity of what's happening. In theory, if every person in California could simply go into his website and apply online, then his eligibility information, according to PPACA, would have to be verified by everybody you see on the screen here. Now, that's a tough thing to do because we don't have one supercomputer that can contact the IRS and look up how much money I reported that I earned last year. I don't have a supercomputer that at the same time can go into Homeland Security and check my status there, or my Social Security number, or whatever it may be. We have to have systems that the person eligible for benefits, such as food stamps, can interrelate to the agricultural department or departments that function for Medi-Cal or Medicaid. That's quite an extensive task of functions that has to be created. Whether all that can be done by January 2014 is anybody's guess, so we've got to assume that there's going to be some paper processing involved, and that eligibility will not be as simple as simply log in, give some pieces of information, and get an insurance card an hour later. The other factor is that eligibility is obviously going to have to test people. PPACA requires that only citizens be involved in getting the health insurance, that only citizens get the premium tax credits to help them buy the health insurance. So people who are not legitimate need to be scrubbed from that eligibility system in some way. In addition, because premium tax credits are predicated upon your federal poverty level, some system has to be done to figure out whether people are telling the truth in terms of what they claim with the IRS, how much money they're making, et cetera, et cetera. So there's a lot of activity that has to be done from an electronic point of view before this thing gets up and running. So we've got to assume that there'll be paper-based, phone-based, and other kinds of activities in order to get all this stuff running by January 1st, 2014, and then I suspect more technology will come into play as the years go by. The exchange operation is, in the simplest form, has to take a bunch of different carriers and a bunch of different plans and standardize the information so that somebody can compare them. So that somebody going in the exchange can compare a Health Net individual product with a Pacific Care, whatever it may be. Obviously, the exchange has to decide who's going to be allowed to sell in the exchange, have to certify in contract with a qualifying health plan. It's highly likely that most of our carriers in our state would qualify, since we have a very, very robust licensing system already. But if a carrier from out of state wanted to come in, they would have to pass muster with the exchange before they'd be allowed to do that. The other thing the exchange has to do is inform, screen, and enroll people who are eligible for the various social safety net programs that are around. Medicaid, or what we call Medi-Cal, Healthy Families, or any other applicable state or local program, and that includes food stamps. That's one of the greatly misunderstood things about the California exchange for a lot of brokers. While there will be the possibility of an individual buying a private insurance plan through the exchange, the same people running the exchange with those same systems have to be able to tell if a person is qualified for Medi-Cal and to move them into the Medi-Cal program. It's a very complex set of tasks that have to be completed. And the exchange has set up certain touchstones, if you will, benchmarks. And the first one is they want to make sure that there's no wrong door. By what they mean by that is that anyone coming into the system has to have some way to make sure that they can leave with the coverage they want. That doesn't mean they're going to leave with it overnight or the next morning, but at least to be able to make sure that the necessary information of eligibility gets to the appropriate private or public services that this person qualifies for. So as an example, no wrong door could be somebody coming through a keyboard through his website. No wrong door could be a very poor person going down to a government agency and applying for Medi-Cal. And that government agent would be able to go into the exchange and get them to the Medi-Cal, or perhaps a nonprofit organization like a church might be helping poor people do that. A broker may be the person helping that person. Obviously, not everybody's going to have computers, so there's going to have to be some way to do it by phone, perhaps, or by written paper. But the goal is no wrong door. However a person comes to the exchange wants them leaving with whatever it is they can deserve, that they deserve, and what they want. Secondly, though, the touchstone is that it's completely invisible. If you go back and think about that exchange, electronic exchange model we showed you, the imaginary computer, and the fact that it was going to be testing for Homeland Security, Social Security number, how much money you made, et cetera, that means there's a great deal of identity someone will have to supply to the exchange. And to avoid the concern of somebody feeling that once they start talking to the exchange, if they disclose something such as their lack of citizenship or they start to disclose, they didn't realize they have to disclose how much money they're making, and they suddenly realize their statements are going to be checked against the IRS. The system is being designed so if the person says, wait, stop, I want to back out of this, I don't want to be involved, that the information that has been gathered completely disappears and is not kept within the system. Those are the two major touchstones, no wrong door and complete invisibility if the person decides not to complete the transaction. Exchange operations are manyfold. Some of them we can do or assist in as agents, brokers, some we cannot. For example, calculating eligibility for premium tax credits and various cost-sharing features that are going to occur in an exchange, we, as a broker, would not be very likely to be able to do that simply because we don't have access to the IRS files. We don't have access typically to the household incomes to be able to calculate those kinds of things. Clearly, somebody within organized either through a subcontract, outsourcing perhaps, or even a government employee may be involved in that. And that's, of course, what the Navigator program is all about. Many brokers confuse a Navigator program with just the selling of the product, and that is not the case. The state exchange is obviously going to have call centers. A call center may be government run, may be outsourced. It may be a nonprofit organization, but would need a call center or someplace of contact for people that typically a broker or an agent would not work with. Say someone very low on the income level. We as brokers and agents would not be enrolling them into Medi-Cal. Somebody would need to be doing that. Obviously, we'd be involved in selling individuals and groups just as we do now. Those individuals and groups, as we've commented, we either go to the individual exchange, which is different than the small business health option exchange, the shop. And this exchange, with all this computer stuff, has to operate in a real and virtual world, because obviously a lot of people are not able to go to the virtual world of the website and make everything happen that's going to be needed to get them into an insurance policy. The functions that an exchange does breaks really into 4 categories. One of the categories called outreach is simply to go out and get people into the system. We're getting those people in the system, whether they be healthy family members, Medi-Cal members, individuals buying individual policies, small groups buying policies, whatever it might be. Access means there has to be many, many points, no wrong doors, and each of those points of entry have to be manned in some way or another. Integration refers to the fact that once someone enters into the exchange to look for a particular program, the exchange would become the single source point for everything available on the government and private side. Now, in a hypothetically perfect California world, that would mean that all the government entities currently running Medi-Cal, for example, would be integrated in the exchange. All the people currently doing work for qualifying people for food stamps integrated in the exchange. All the people qualifying people for healthy families or whatever government child program might be available at a future point integrated in. Now, we know that not a whole bunch of people are going to be fired from the California state government and integrated in the exchange overnight, but that's the goal long term. But along with integrating everything when a person is first entering the exchange, what about after he gets in? Interoperability means that the exchange has to have some way to move people around. They have to move them between the private plans that might be offered in the exchange versus, say, Medi-Cal, because someone could qualify for some premium tax credits to buy a private plan in exchange. Suddenly they lose their job. They don't have income at the level that's required for the premium credit exchanges, and they become eligible for Medi-Cal then. That person and his family has to be moved around and about. But we'll talk about all 4 of these things as we go along. Let's talk about outreach. The chart you're looking at is a chart that shows the California goal of the percent of business that will be coming through its different doors. As you can see, the vast bulk of the goal, about 18% of it, will be people who come in eligible for premium tax credits. These will be people who will be making lesser amounts of money typically. There's also, they say about 3% is going to come in as people who just cannot pay anything at all. Those be our totally free folks. But the green and the red are small employers and individuals who will come into the exchange without any subsidies. This is an important part, and it represents about 34% of the bulk, because if you think about what basic risk pool analysis says, if I take everybody in America, I know that about 92% of the people in America who are putting money into insurance products or governmental programs are helping to pay for about 8% of the people in America who make up the vast bulk of the really expensive sicknesses. That's the way a risk pool works. A bunch of healthy people supporting those who are in the minority who get very, very sick. Simplest way I like to explain it to a client is, imagine how many full-paying customers have to buy their health insurance month after month after month, paying those premiums into Blue Cross or Blue Shield or whoever it may be, to pay for $1 million preemie baby. A lot of perfectly healthy people not getting anything in exchange in any given year have to be that way to cover the $1 million cost. It's the same thing in the exchange. While the exchange is supported with many kinds of tax dollars from the federal and from the state, they still estimate they need 34%. That 34% is basically your customers, and that's, of course, where you as an agent or broker comes in. We are not skilled at enrolling Medi-Cal people or people who are poor enough that they can barely afford a policy from us today. They're probably not our customers. But our customers, small employers and individuals currently buying from private markets, may be part of the purchases that occur in the exchange if the exchange does its job correctly. Well, that outreach is to try to go after that somehow, to either sell it or promote it, advertising, marketing, etc. And one key promotion point on the individual exchange will be that premium tax credits come to an individual only through the exchange. Navigators, in a general sense, are anybody who steers somebody through the exchange to make all this kind of thing happen. So while we wouldn't call a broker a broker is doing some of the navigator's job. The navigator is really that full set of tasks, from eligibility to enrollment to helping them understand what their benefits are. It's a multifaceted job. And in California, some parts of the navigator job will be done by brokers, agents, some by call centers, perhaps subcontracted by the exchange, some by government employees. It'll just depend on what part. Obviously, promotion, if it's going to be done right, has to be by a navigator, and the right type of navigator, somebody who can get out there and sell. And that's, of course, why they've made the decision to include brokers and agents. Obviously, decisions at state level will dramatically impact the success of a given program. If the exchange needs brokers to sell healthy small group into the exchange or healthy individuals, then they're going to make rules about commissions, as an example, that make the commissions comparable to what's in the private market. Broker involvement is going to vary from state to state. So you may have a state like Vermont that decides it doesn't want to use brokers. That doesn't mean that it'll be the same way in the state of California. And in fact, if a state understands selling that 34%, which is healthy, requires active selling, not passive outreach, then they'll recognize that certain kinds of enrollees will come in through the passive navigator, and others will be brought in by the active broker. States' compensations will obviously be a key. I'm happy to report that the exchange notes and decisions they have made so far will be that individual policies sold through the exchange will have compensation to the broker, and the compensation will be paid by the carrier, not the exchange. So if the exchange decides to allow 2 of Blue Cross's individual policies into the exchange, if a broker sells that Blue Cross policy, then Blue Cross will be responsible for paying the commission to that broker. The shop, the small group, that obviously they will have to make a decision how to pay commissions. Since obviously, as is the case with California Choice, you may take a small employer into the shop exchange with 10 employees, and his 10 employees may choose from 10 different carriers or 10 different plan designs. So the shop will have to coordinate the commission payment for the small group stuff. Brokers are obviously going to be a critical component of this outreach because the exchange needs that unsubsidized sales. And to give you an example of what we mean, in the state of Massachusetts, they have unsubsidized sales, what would be the green and red in our model, of up to 40%. So California is suggesting they get by with a little less, but either way, there's a lot of sales that has to go on, and that's going through brokers. Think of it this way. If every low-income worker in the state of California was pushed into the exchange and every one of those brokers walked out with premium tax credits, the exchange would have a very big problem because there's only so much money to go around. Obviously, they need an actively functioning outreach, and that's going to be done through people like us. Obviously, as the critical component, private employers voluntarily covering their employees, even though they have low income. That's what we're doing today, and the exchange doesn't pretend to change that. It simply basically is a new option in terms of the arrows in the quiver that a broker can be using in the selling market. What's the second category beside outreach? Well, access. I mentioned the fact that in theory, the exchange operates as a computer-based model. But that theory gets hampered by the reality that, particularly in California, that lots of people simply cannot approach the exchange through that mechanism. There are going to be people who have to have telephone entry. There are going to have to be call centers that are going to be involved in this sort of thing. There are going to have to be non-computer paper-based sales. I can envision farming cooperatives in the San Joaquin Valley where they might literally have to drive buses outfitted like a library bus to have people enroll on a paper-based system. There certainly could be storefronts. There's nothing that stops that. They might have a strip mall where they have the Don Golmann Independent Insurance Agency next door to the State Farm Agency, next door to the exchange storefront. That would certainly be possible. The exchange will have the same kinds of problems that we as salespeople and as our carriers, as providers of product, have today. There'll be illiteracy challenges, there'll be language problems, there'll be rural problems in the upper northern part of California or far out over towards the Arizona side in the deserts. Those kinds of challenges are the same ones that we face selling every day, and the exchange will continue to face those as well. Nothing different there. On integration starts by the fact that our exchange is not saying they are going to be the insurance company. They will be running Medi-Cal. But the rest of the time, the products the exchange sells will be the products that we sell in the open market. Carriers will be invited in to make a bid to sell product through there. The rules are going to be such that the exchange wants the individual who is contemplating purchasing through the exchange to be able to do a comparison of both what's inside and outside the exchange. So if a carrier, such as Mr. United, decides they're going to sell an individual policy, we'll just call it the XYZ policy inside the exchange, that policy will also be sold outside the exchange, the identical policy. Pricing may eventually become different on it because obviously they'll be different, working with different risk pools as time goes on. But what is clear is, and we need to make sure everybody's aware of this, the exchange will have some number of plans and carriers. Mr. Blue Cross may sell 2 of its plans inside the exchange, but that does not mean that's the only plans that Mr. Blue Cross will sell. Outside, they will sell the same 2 as inside, but they may offer 35 other different plans or 20 different plans or whatever it may be. The carrier is not limited on the outside to what he can sell. It's simply that if he is in the exchange, he'll have both policies available inside and out. What that also means then is the individual who goes in the exchange has to be integrated in a way that he could move from his XYZ policy inside the exchange to his XYZ policy outside the exchange if that's what he wanted to do. He could be integrated in order to access healthy families. If he himself was eligible for a private individual policy, but his family was eligible for the healthy family side of the program. The exchange will be ultimately, this may not be by the 1st of January 2014, but ultimately the exchange will be the only source for Medicaid, or what we call Medi-Cal, for food stamps, for temporary aid for families, for healthy families. And obviously, as the only source for all those things, they're going to have to coordinate with HHS in the federal government and with the Treasury to determine qualifications. That integration, by the way, goes one step further. If an individual wants to come to the exchange to purchase an individual health insurance policy, and if they are qualified, for example, Medi-Cal, the exchange will mandate that they sign up for the Medi-Cal product. They will not let that individual buy a private product through the exchange and get the premium tax credits from the federal government. If an individual qualified for Medi-Cal could afford an individual policy and wish to have one on a private basis, he would have to buy that policy outside the exchange. The coordination with HHS and Treasury, we don't know how that's going to be done. In reading the discussions and the kinds of things that have been reviewed, we suspect that for a while it will probably be done through some type of data transfer, perhaps at a coordinated time, once a week, whatever it may be, maybe on a nightly basis at some point. There might be some paper that has to be checked and exchanged, because there is no single live-time computer coordinating all this stuff at this stage. That also tells us that they'll have to integrate this with the enrollment policies of the private carriers. If Mr. Kaiser is selling an individual policy through the exchange, if they are not set up to do effective dates of every day of the month, some marketing and operational decision will have to be made that it might be the 1st of the month after 30 days, or that enrollment can only occur on the 1st and the 15th, or whatever it's going to be. Those decisions have to be made, but it's not going to be an immediate, I call it today, get my policy tomorrow, because there's too much integration that's going to have to occur. Also, within that exchange, it's going to be a private source for what we've talked about earlier, bronze, silver, gold, and platinum. And let me describe a different kind of policy for just 1 second. We call it a catastrophic. In the law, it's called sub-age 30 catastrophic. What that simply means is PPACA allows someone to meet their legal requirement for coverage to buy a large deductible plan only if they are under the age of 30. So an essential benefit plan with perhaps a large deductible such as $5,000 would be available to someone either through employer or individual basis and only if they were under 30. Now, we don't know what size deductible is going to be considered catastrophic or approved. The exchange will be making that decision. They'll also have sub-age 30 products available. Once someone hits age 30 or higher, then they have to go into the bronze, silver, gold, platinum type of coverages we talked about before, and we'll talk about again in the next program. California has passed a law that will prohibit a carrier from selling only sub-age 30 catastrophic policies. That's a rather logical rule, because if someone could market in only that category, they would get the healthiest of the healthy. And obviously the intent here is to spread risk around. Non-exchange carriers, in other words, even a carrier who chooses not to be in the exchange, or maybe his plans were not accepted to be in the exchange, will have to sell at least one standardized plan within these 4 metal categories, similar to what's inside the exchange. That way, again, someone will be able to exchange to compare policies both in and out. Interoperability. Well, obviously, we've got to be able to move data about people and move their eligibility around once they get into the exchange. A person can come into the exchange and qualify for Medi-Cal. He could get a new job or get extreme pay raise, obviously making him ineligible for Medi-Cal. Somehow the exchange would have to be able to recognize that and promote a private offering to that individual with tax credits at that point. And that's going to be a very difficult task, and the computer work to accomplish that is going to take quite some time to do. Obviously, a person inside the exchange is going to have a need to be able to move between different plans. He might be in the exchange with his Blue Shield plan at the moment, decide next year he wants to go to Kaiser, and the year after that go back to Blue Cross. That kind of activity is going to happen. We're going to have to be able to move people inside and outside the exchange as life circumstances warrant. And we're going to have to move people based on what I call a changing life event. I think of these things as COBRA. It's not COBRA, but I think of them as a COBRA type of event. For example, if you were to be inside the exchange and you cross the federal poverty line, you might be getting, for example, 50% of your premium paid for as a premium tax credit because you make very little money. While your income didn't change, perhaps you added another child. That would then, because of having the additional child, boost you up in terms of additional premium tax credits you could get. On the same token, you'd be getting tax credits, and suddenly your spouse gets newly employed, and now you're above any of the federal poverty level, and the exchange would have to know to cut off your premium tax credits. All sorts of things could occur. You could have changes affecting the premium, such as adding or dropping a dependent child, adding a new baby, losing a dependent off of a family plan. Obviously, the exchange will have the same financial viability issues that we have in the open market. The exchange is using private carrier plans, which means their premiums being charged will have the same effect as when medical services that are contracted go up or change. If Mr. United loses a contract with the UCLA Medical Center, an IPA, that contract for those medical services is going to be lost outside the exchange and inside the exchange. There won't be any difference on that. When contracts get renegotiated, premium rates have to go up, be inside and outside the exchange. The exchange lack of competition in the rural area is going to be handicapped both inside and outside the exchange. IPAs. Obviously, an IPA can only accept so many patients and bear so much risk under the Department of Managed Healthcare rules. If a large number of enrollees suddenly come into a given area through an exchange contract, and if the Department of Managed Healthcare is telling an IPA they cannot take any more patients, then that conflict with open slots will be the same as you experience when you enroll a group and the doctor closes his panel unable to take any additional people. There won't be any magic solution to that inside the exchange. There could be, interestingly enough, some potential judicial conflicts in the sense that a large enrollment coming through an exchange product may set up the Department of Managed Healthcare to go in and tell an IPA to cut back or not accept patients if they think they're bearing too much risk. Those kinds of problems will be solved as we go along. Finally, healthcare providers, they will have the same kind of choice to refuse contracts or payment levels that they do today. Just as a St. Joe's can renegotiate and then finally not accept a contract from one of its carriers, the plans inside. Likewise, Medi-Cal doctors may not accept the payment levels or the number of new additional patients that come through the exchange for them. All the same kinds of problems and financial viability in the exchange as outside the exchange. When it comes to exchange politics, I'm happy to note that the exchange has the same kind of conflicted interest as any private marketer, because after all, they are marketing with private plans. When Assembly Bill 52 came up for review in the Assembly and in the Senate, it was a bill that would have allowed the insurance commissioner to regulate rates on private carriers. The rates, in theory, are supposed to be the same inside and outside the exchange. So rather obviously, a bill like AB 52 could really complicate that kind of thing when the insurance commissioner would be allowed to regulate rates. In effect, what could happen in an AB 52 situation would be the insurance commissioner would be effectively running the exchange via his power to review rates, plans, benefits, etc. So the exchange, even though it is a governmental-based entity, chose to not support and work against AB 52, which many of you know as of the September 2012 was not passed and was shelved. May come back, but it's interesting to note that the Exchange Board understands that the same kind of things that would negatively affect a private carrier could negatively affect the insurance exchange. Obviously, the exchange is going to be concerned about all sorts of special interests rushing to get more medical conditions to become mandates. For example, in Minneapolis, there's a mandate that if you have chemotherapy and your hair falls out, your insurance company pays for a wig. Well, if that type of mandate was suddenly tried to rush through our California legislature, that would obviously affect our private carriers as well as the benefits and costs inside the exchange. Obviously, the exchange doesn't want to have a sudden influx of a lot of cost it doesn't need any more than we would. Another example of exchange politics that kind of worked to the typical broker favor. Inside of the PPACA, there is a ability for a state or individuals in the state to create a state co-op on what's known as a basic health program, a PHP. Two assembly people attempted to push that bill through our state assembly, and the Exchange Board worked against that bill as well. The obvious concern was that if a cheaper co-op plan funded by more aggressive federal dollars was to be put up, it would be in effect in competition with our state exchange, and the exchange was afraid that that would siphon off people from going from the exchange into this different co-op type of program. And obviously, the state exchange, working through private insurance carriers, needs as many bodies in there as possible to enhance their negotiating power for better benefits and lower rates with a private carrier supplying the plans. It was estimated by the exchange that they could actually lose from 720 to 950,000 members leaving the exchange for this co-op type of program. And so the Exchange Board fought, as did the broker and the agency groups here in the state, fought against the creation of that particular co-op. There's a great deal of fear that with effectively a co-op and an exchange that people will be flipping back and forth between the two programs, depending on where the best support was in terms of tax grants and free coverages, as well as when they changed in terms of their federal poverty levels, how they move back and forth to take best advantage of it. Obviously, the administrative costs of people moving back and forth like that would be tremendous. So, as I said, the state board did side on the same side as the private interests were in that particular case. By the way, just for your education, while it's not being established here in California, this co-op program may be established in other states that you might do business in. It'll be for individuals and small groups. The intent behind this co-op is that there are some states, take Tennessee for example, where there's very limited availability of plans. Basically everything's what they call the 10 plan and one operating Blue Cross Blue Shield plan. There's not much competition, and it would be very hard to establish an exchange in a state like that where there isn't anything to a variable enough to create an exchange. So PPACA envisioned allowing consumer-oriented groups to create these kinds of things. This is not unheard of. Co-ops are created in rural areas for the development of water companies, for example. Sometimes there's co-ops to provide satellite TV. Back in the 1930s, co-ops were used to create health plans in rural areas of the country where our big insurance carriers really didn't participate. These kinds of plans were member-run. In other words, the very people who buy into the plan also get to vote on the plan, much like a mutual exchange person might do. It would have to meet state status for qualifying plans, but in the co-ops, any profits that come into there would be used to reduce premiums to help the co-op be self-supporting. In our state, it was SB 703 that would sell this basic co-op, and as I said, the HBEX worked against having that thing run. Generally speaking, it wasn't envisioned that a co-op would be also run in the state with a robust exchange, because it wouldn't be needed. But we'll have to see whether the guys who created this bill in California want to bring it up at the next legislative session. In California, by the way, because of the amount of money that was available from the federal government for co-ops, it was feared that the BHP, the Basic Health Plan, might run as little as $20 per person per month until the funding ran out. And then, of course, you'd have 720,000, 950,000 people without insurance that would flood the exchange, and that would not be a good thing either. So what have we concluded about? Number one, what we'd like you to think in terms of is that exchanges, particularly in the state of California, where we're getting market-oriented and somewhat broker-friendly decisions at this point. We can't guarantee that every decision currently being discussed will be implemented that way once it becomes operational. As is often said, until every I is dotted and every T is crossed, we can't guarantee anything. But at this point, it looks like that our exchange will be another selling opportunity for brokers. It'll be a multi-level plan using the same carriers that we work with today. It'll simply be available in a single source, very much like the private exchange California Choice does. The public and private exchanges will still continue to be available here in the state, and we are going to be moving forward regardless of what the federal government decides to do after the elections. What's probably most important for you in terms of this webinar is we need to become comfortable and knowledgeable as the exchange rolls out about the different ways that outreach, access, integration, and interoperability will be run. We know from the testimony so far that we've read that the exchange intends to have some sort of training system for brokers to educate them about these areas. So our guess is that a broker will have to be properly licensed, as he is now, and will have to go through the exchange's training program. It appears that they're talking about training through a website rather than an in-person kind of website. There is also discussion being done that if people are going to be doing navigation for the things like Medi-Cal and those kinds of areas, that if they also want to be selling, that they would then have to be licensed to do that kind of selling. So we'll probably have some cross-training both ways, brokers who want to do some of the navigation work and navigators who want to do some of the selling work. But stay tuned for those opportunities. We'll bring them to you as soon as we discover them. In the meantime, we suggest you stay in touch with your local health underwriter organizations. They are assisting and sitting on advisory boards with the state of California, and they may be your best source for keeping up on the latest and greatest with what the exchange is doing here in California. We'll come back in a few moments and handle course number 3 in this 4-course set.